Recurrent loin pain. Letter of referral. Dear Dr. Mr. Lawrence Perkins, aged 46 years. This man, with no past medical history of note, has had several episodes over the past few years of severe right-sided flank pain, following which he has sometimes noticed gravel in his urine. He recently had a particularly severe attack when away on holiday that took him to the emergency department of the local hospital, where he required diclofenac and pethidine to ease the pain. Stimulated by this, he came to see me. I would be grateful for your advice as to what we should do about his kidney stones. Yours sincerely. Introduction. Urinary tract stones are a common problem. They typically present when they enter the ureter, causing colic and/or obstruction. If present in the renal pelvis, they make urinary tract infection much harder to eradicate. Aside from confirming the history of loin pain and passage of gravel and stones in this case, the history must focus on the well-recognized predisposing factors for stone formation. In deciding on the correct treatment, it will be very important to determine the chemical composition of the patient's stones, if possible, because different types of stone require different treatments. History of the presenting problem. To confirm that the patient has had pain from urinary stones, renal colic is usually of sudden onset and very painful. It occurs typically in the loin, radiating to the suprapubic area, and is often spasmodic in nature, occurring in waves lasting from 30 minutes to 1 hour. Nausea and vomiting are common symptoms. The patient may notice hematuria, and dysuria is common when stones are in the bladder or passing through the urethra. Strong analgesia may be required. As in this case, an episode of pain followed by passing a stone or grit in the urine establishes the diagnosis. Previous episodes. There will often be a previous history of urinary stone disease, as seems to be the case here. Ask the patient directly whether he has had any tests done for these in the past. Have you ever had X-rays or scans done to look at the kidneys or bladder? Have you ever seen a neurologist or a kidney doctor? In routine clinical practice, it would be not at all uncommon for a patient not to have mentioned these to the GP, and in PACES the instruction to the patient could well say, do not mention this unless asked directly. Other relevant history. Ask about the following risk factors for urinary stones. Fluid intake. Ask the patient what he drinks over 24 hours on a typical day. Go through this carefully. When you get up, what do you drink at breakfast, and then during the morning, and at lunch? Low fluid intake is a major risk factor for formation of all types of stones. Diet. High oxalate intake, spinach, tea, nuts, and chocolate, and high protein intake predispose to calcium stones, the commonest sort. Time in hot climates. Increased perspiration leads to decreased urine output, hence stones are much commoner in hot climates. This might be relevant in this case if the man had spent 10 years working in the tropics. Once stones form, they are very slow indeed to resolve, even if the precipitating factor is removed. Hypertension. Urinary tract infections. These predispose to stones and are also more likely in those with stones. Gout, suggesting increased uric acid production and excretion, is a risk factor for uric acid stones. Drugs promoting crystalluria can rarely cause stones, e.g. triamterene, indinavir. Family history of stone disease. If many family members are affected, then obviously consider genetic causes, including medullary sponge kidney. Also consider the following. Are there other symptoms suggesting hypercalcemia and/or hyperparathyroidism, such as thirst, polyuria, abdominal pain, depression, or aching bones? Increased oxalate absorption from short bowel syndrome. Has this patient had any intestinal surgery? Plan for investigation and management. Examination of the urine. Spot urine sample, check urinary pH, specific gravity, and microscopy for crystals, and then send for culture. A pH greater than 7 with phosphate crystals is suggestive of magnesium ammonium phosphate/calcium phosphate infection stones. Hexagonal cystine crystals are diagnostic of cystine stones. 2 24-hour urine collections are required, one in a container with acid preservative for analysis of volume and excretion of creatinine, calcium, magnesium, sodium, potassium, phosphate, oxalate, and citrate, the other in a plain container for analysis of volume, creatinine, pH, protein, urate, and a qualitative test for cystine. Chemical examination of the stone, if available. Ask the patient if he has saved a stone. Sometimes people do but may not volunteer this information, only revealing it if asked directly. Expect to find one of the following: calcium oxalate/phosphate, common and not specific; uric acid, uricosuria; cystine, cystinuria; magnesium ammonium phosphate, usually with calcium phosphate, suggests stones caused by chronic infection with urea-splitting bacteria. NB. Always ask patients if they have saved any stone and gravel that they have passed. Analysis is crucial to direct specific treatment. Blood tests. Check creatinine and calculate estimated glomerular filtration rate. Estimate sodium, potassium, calcium, magnesium, phosphate, bicarbonate, urate, albumin, and alkaline phosphatase. Consider measuring parathyroid hormone. Imaging. The test to perform at the first outpatient attendance would be an abdominal radiograph of the kidneys, ureter, and bladder, which would show any radio-opaque stones. The single most useful test to look for stones within the urinary tract would be an unenhanced CT of the kidneys, ureters, and bladder. An intravenous urogram would offer a reasonable alternative to CT. Ultrasonography of the kidneys would be the appropriate test if obstruction were suspected, but there is nothing in the letter of referral to suggest that this is likely in this case. Management. The management of patients with urinary stones includes general measures and specific measures based on the type of stone, where this is known. General measures to decrease stone formation. Ensure the patient drinks enough water to increase urinary output at over 2000 ml daily. Decreases animal protein intake. Reduces dietary oxalate, spinach, tea, nuts, and chocolate. NB. Whatever the cause of urinary stones, get the patient to drink more. Specific measures for specific stones. These include the following: calcium oxalate/phosphate stones, potassium citrate and thiazide diuretics. Urate stones, potassium citrate and allopurinol. Infection stones require eradication of urinary sepsis. Prolonged antibiotic therapy, 3 to 6 months, is often required. Note that these stones are associated with alkaline urine and are not helped by giving alkalis such as potassium citrate. Cystine stones, penicillamine, captopril, or alpha-mercaptopropional glycine. Underlying medical causes of stones, such as hyperparathyroidism, need to be treated, and chronic renal failure, if present, would require management along conventional lines. Further discussion. What happens if a symptomatic stone doesn't pass? Urinary obstruction must be relieved, usually by percutaneous antegrade nephrostomy. Stone removal can be effected by percutaneous endoscopic or ureteroscopic procedures, or by external shock wave lithotripsy, depending on the site, size, and type of stone and on the availability of technical expertise. Open surgery to remove urinary stones is rarely required, but remains the best option in some cases.